So welcome everyone. It is our BC Thrombosis Network rounds, and today I'm going to present cancer-associated thrombosis and focusing on the Canadian consensus algorithm that was actually updated in 2021. This apparently was a frequently requested topic, so that's why we're covering it today. For those of you who just joined, we're going to try to stick on time. Most of you know that when I'm running these meetings, I tend to run over time because we have great discussions, but I will do my best to be on time. And I'm going to assign Taylor to keep me honest and keep me on time because he's the only one I can see on video. That's why. Okay. Cancer-associated thrombosis. Oh, here we go. My slide. Oh, there we go. So disclosures. So I've worked with a number of companies that market anticoagulants, and I've participated in clinical practice guidelines for ASCO, ASH, ISTH, and Thrombosis Canada. So certainly some of my opinions or some of their sort of guidelines do reflect some of certainly what how I look at the literature. So the main objective is really to present updates to the Canadian consensus algorithm for acute CAT treatment. And also, I hope we do have time to share our experiences, you know, in our current practice in BC, and perhaps discuss some of the challenging scenarios. In terms of funding, I want to make sure that everybody is aware. So the Canadian consensus algorithm was developed through an unrestricted grant to Thrombosis Canada from a number of companies. And then Thrombosis Canada invited, you know, us, some of the experts to develop this guideline or algorithm. And basically the funding, you know, sources had absolutely nothing to do with the drafting, editing, approving, or anything. They weren't even present at the meetings at all. So in terms of cancer-associated thrombosis, many of you are familiar with this because this group of patients represent a large subgroup of patients with thrombosis. Approximately 20% of all thrombotic cases are associated with cancer. And with some of the latest epidemiology that's been published, the risk of thrombosis is about 12-fold higher in cancer patients and 20-fold higher if they're receiving cancer therapies. It is the second leading cause of death in cancer patients and certainly contributes to significant morbidity, you know, down to, you know, increased financial economical burden. And certainly for cancer patients, the most feared sort of outcome is really interference with their cancer treatment. And unfortunately, as the prevalence of cancer increases, we will also see an increase in the burden of cancer-associated thrombosis. And right now, anticoagulant therapy is the only effective treatment available. So on this slide, you see, I don't know if you could see my cursor. Yes? No? Okay. You can see that this is from a study from Mulder et al. Published in Blood, and you could see that the incidence of VTE in cancer patients is going up over time, whereas it's fairly stable for the non-cancer population. This may be partly due to, like I said, the increase of, you know, prevalence of cancer and aging population, but probably also to the number of incidental, you know, clots that we're now detecting on restaging CT scans. This graph shows you the increased risk of thrombosis in patients when they're receiving treatment. So here's a group of cancer patients not on therapy, but whether they're getting chemo, kinase inhibitors, angiogenic therapy, immunotherapy, it's all increased. So clearly this is an important and prevalent population. In terms of the anticoagulant therapies we have available, this little arrow shows you sort of the evolution of anticoagulants. And over the past 100 years, we don't have many classes of anticoagulants. And and somewhat surprisingly, we're still using an anticoagulant that was first discovered over 100 years ago. This probably doesn't actually exist in other areas of medicine, but so certainly a bit surprising. But it also shows that our sort of old-fashioned traditional anticoagulants, heparin and vitamin K antagonists, how effective and in some ways relatively safe they are, because they are still preserved in practice. But clearly, we are moving towards simpler and easier to administrate anticoagulants. But because we have now various options, it somewhat complicates treatment, because if you only have a hammer, as they say, everything's a nail. But when you have choices, then we have to sort of think about how do we best deliver the choice. So all of you know this in terms of the anticoagulants available, especially the direct oral anticoagulants, and they are very similar, but they're also different in some ways, particularly in terms of the renal clearance, their hepatic clearance, the drug-drug interactions. And they also have a bit of nuance sort of things about the Bigatran. It needs to be sealed. There's no direct comparison with low molecular weight heparin in the cancer population. Rivaroxaban must be taken with food. Apixaban is given twice daily. And edoxaban, which actually in some ways has a very good profile because it has the sort of the least drug-drug interactions, unfortunately is not covered by pharmacare in BC, is covered in all the other provinces. And so we see quite a bit, we don't see a lot of use of edoxaban in BC because of the pharmacare coverage. So clearly, with these options available, one of the things we have to decide is, how do we choose the right anticoagulant? And so if we look at clinical guidelines, there are a number of them. And even though they have spanned in time from 2013 to most recently July 2022, they are surprisingly similar as opposed to dissimilar, and that they all now recommend DOACs and low molecular weight heparins over vitamin K antagonists for treatment of CAT. And they also all recognize an increase in bleeding with DOACs, particularly in patients with GI and GU cancers. And this is really based on the large randomized trials that have been done. Drug-drug interactions must be checked before you use DOAC. And unfortunately, we still have a lot of sort of problematic areas, certainly for clinical purposes, where there's just not a lot of evidence, certainly no randomized control trial evidence, and even sort of the observational stuff are largely retrospective. So there are still very important and large groups of patients where we are really extrapolating results from large randomized trials, and sometimes, just do give us difficulty in the clinical setting. So the Canadians, instead of sort of given that kind of, general perspective like all the other guidelines, the Canadians decided to get together to develop an algorithm sort of to help us think through the problem, as opposed to, you can use DOAC or low molecular weight heparin. But here it really sort of tries to make you think, okay, how do you approach the problem? And so to help you select the right drug. And this is the algorithm that was published in 2021, and it's widely available online. And this is actually an update from an earlier version. And you could see it looks a bit complicated, but it actually isn't. And I'm going to sort of go through the various steps with you and not only highlight the differences from the previous algorithm published in 2018, but also some of the sort of even newer data that have been published since the publication of this guidance or algorithm. So I do use this algorithm, but in a somewhat slightly different way, and I'll show you that at the end, but it really does sort of follow through sort of this thinking. So again, I just want to let everybody know. So the revision of this algorithm was evidence-based. So there were 11 physicians with expertise in the area who were invited to participate. So we all met through web-based teleconference because this was during COVID. And we looked at the literature that was updated from the last algorithm in 2018. So we found 22 articles, all right, new articles, and we added 12 additional articles that we had from just literature search, and conferences, as well as one abstract. So based on that, we revised the algorithm, we did a manuscript that, we circulated and revised, and then the final version was published. And but as you know, all of you who've been in committees and so on, sometimes there are some disagreements, but overall, certainly the algorithm and the flow was all achieved by consensus. So I'm going to sort of give you a high level summary right now, just because in case some of you do have to leave earlier and I break my promise in keeping this short. So summary basically provides guidance on the selection of anticoagulation, all right, and in patients with incidental or symptomatic thrombosis, and this includes upper extremity, lower extremity, or PE. And basically, low molecular weight heparin is preferred in patients with a high risk of bleeding with unresected or intraluminal, this should be GI or GU cancer, or if they have significant drug-drug interactions with DOACs. And there are additional factors to consider when you're choosing. So obviously, yours and the patient's preference, the drug cost and coverage, body weight, burden of cancer, burden of thrombosis, history of abnormal uterine bleeding, significant GI surgery or absorption disorders. And in general, anticoagulation should be continued in patients with active cancer. So if you have to leave now, this is sort of, like I said, the very top overview, and but hopefully you will stay. The recommendations really are based on the randomized control trials now that have been published that compare DOACs with low molecular weight heparin. And this is the most recent meta-analysis. It was actually presented at ASH, and the full publication isn't out yet, but this was the meta-analysis combining all the published randomized control studies. And you could see when you combine the results, the pooled estimated risk of recurrent thrombosis favors the use of DOACs, all right, with a risk reduction of about 33%. And when you look at major bleeding, it certainly sort of favors low molecular weight heparin, but this is not a statistically significant 20% increased risk of bleeding. So, I mean, overall, I think practically, DOACs and low molecular weight heparin are quite balanced in terms of their efficacy and safety. And so for the large majority of patients that were able to get in clinical trials, you can use DOACs or low molecular weight heparin and not have to worry too much about, a significant difference in efficacy and safety for these agents. But clearly, for experts, we want to also look at other factors and not say, okay, DOACs for everybody or low molecular weight heparins for everybody. And one of the things that actually, Lim, I don't know if he's on, but, and actually Wendy, I saw her earlier in the, did, and during the residency was actually to do this incredibly extensive meta-analysis to dig out the case fatality rates. And this is the first and only article to date that actually looked at how likely a cancer patient is going to die after a recurrent thrombotic episode or a major bleeding episode while on anticoagulant therapy. So you can see this meta-analysis included 14 randomized controlled trials, 15 prospective cohort studies, 8,000 cancer patients with, almost 48,000 patient years of follow-up. And you could see in the various studies, the case fatality rate actually varied tremendously from, almost nothing to almost 50%. And if you sort of pool them all together, the case fatality rate is 14.8%. Whereas if you look at major bleeding, similar results in terms of case fatality, all over the place, all right, but overall it seems to be lower than the risk of recurrent thrombosis. So if you say the risk of recurrence is say higher than major bleeding, and you're more likely to die of a recurrent thrombotic event, it's very clear that you should continue anticoagulation in these patients. So regardless of which agent you use, you should certainly continue if the patient has active cancer. And in this meta-analysis, Wendy and Lim tried to tease out, was there a difference between DOACs and low molecular weight heparins? And unfortunately, there just wasn't enough data for us to sort of really be able to show any differences between the agents to date. So this is a busy slide that actually shows you the updated algorithm published in 2021 compared to the 2018 algorithm. You can see they're set up very similarly, and for the most part, this is more of a graphics design change than anything else, because both algorithm really addresses sort of big boxes. All right, and both of them look at incidental and symptomatic thrombosis. However, the 2021 included upper extremity, and basically we recommended treating patients with upper extremity DVT the same way we would treat lower limb or PE. The big boxes to think about is risk of bleeding, the same for both. Type of cancer, the same for both. Drug-drug interactions, the same for both. But the language of using low molecular weight heparin or DOACs was softened to add preferred as opposed to low molecular weight heparin versus DOACs. And again, this really just shows you the nuances that we're starting to get into as we learn more about these agents. And again, the other factors to consider, there's sort of quite a few of them, and they're similar but slightly different. So I'm now going to sort of go through these various areas, sort of starting with risk of bleeding in more detail. So 2018 recommendations, 2021 recommendations, both agree that obviously increased risk of bleeding with thrombocytopenia when the platelet count's less than 50, if the patient's also using an antiplatelet agent, if they've had a recent life-threatening bleed. So not surprising to anybody. In terms of the sort of the GI bleeding and GU bleeding, the language was changed a little bit to be a little bit more precise about what type of GI bleeding or what type of GI lesion. So angiodysplasia, if the patient actually has a GI malignant lesion, if they have previous variceal bleed. And so that's kind of a bit of a nuance. In terms of intracranial lesion, it was again tweaked to say high-risk intracranial lesions like glioma, so suggesting that patients with metastatic brain lesions, the risk of increased bleeding is not actually documented when they're on anticoagulant therapy. And finally, in terms of renal impairment, this was actually removed altogether in 2021 and replaced with hepatic impairment because this is now an important consideration for DOAC. In terms of thrombocytopenia, I just want to give you this update since the publication of these guidance to, again, sort of give you a little bit, there's a little bit more evidence that sort of this sliding scale of low molecular weight heparin that we tend to use in patients with thrombocytopenia with a platelet count of less than 50 seems to be supported by more evidence now. So again, not a lot of strong evidence for platelets less than 50, but the sliding scale where we do use reduced doses, all right, with or without a platelet transfusion support, is now actually fairly common in practice. And this is the first and only prospective multi-center observational to date, and it described 121 patients who used a modified, so this sort of sliding scale low molecular weight heparin dose, and show that it certainly seems to be relatively efficacious and safe, or effective and safe. And so these are cohort patients, they're not randomized. So in these 121 patients, some of them were selected to continue with full dose, some of them were selected to continue on modified dose. So this is sort of these plots show these spindles, all right, shows you sort of the duration of thrombocytopenia in these two groups. So you could see that just eyeballing it, all right, that there were more patients who had, basically adequate platelet count in the full dose group compared to the modified group. And there were more people with sort of, lower platelet counts in the modified group than the full dose group. So it explains why these patients were sort of, given their chosen treatments. Now, when they looked at the risk of bleeding and recurrent thrombosis in these two groups, you can see there's a separation. But before you go off to say, oh, you know what, full dose anticoagulation is associated with a 12.8 risk of bleeding versus modified dose at 5.6%. Remember, these are not randomized patients, right? So they were already pre-selected to receive full dose or a reduced dose or modified dose, probably based on the physician's sort of gestalt to say, hey, you know what, with, full dose, maybe they have a lower risk of bleeding or whatever. It's going to be hard to know. But if you look at the modified risk dose, all right, the risk of bleeding and recurrent thrombosis certainly were not very high, to suggest that, yes, there are going to be some patients who will do quite well on a modified dose. And so there's going to be so currently right now, we've submitted to the NIH a randomized trial to actually compare the two regimens. So hopefully it'll be funded, and then we'll be able to answer this with more robust evidence. In terms of use of antiplatelet agents, not a lot of data, but both, the Caravaggio on the hockey side, randomized control trials showed increased risk of major bleeding with in the patients who received DOAC if they also took antiplatelet therapy, compared to those who were randomized to low molecular weight heparin and also took antiplatelet therapy. So if you have a patient who must take antiplatelet therapy, particularly if they have other risk of bleeding, you may want to continue them on low molecular weight heparin versus DOAC. But again, these are sort of post hoc analysis. But I mean, and it does make sense. We know aspirin does increase the risk of GI bleeds, and because DOACs are active drugs going through the GI tract, maybe it's that combination that makes them particularly vulnerable. And so the Canadian consensus, the committee, does recommend that, if you have a platelet patient who's on antiplatelet therapy, now you need to start anticoagulants, all right? Really check for their need to be on antiplatelet agents to start with, because often patients shouldn't be on aspirin and we don't know why they're on aspirin, right? And you should continue, consider discontinuing if there's no good indication, and, and then sort of decide on your anticoagulant of choice. In terms of renal impairment, this was a criterion that was removed to try to decide on low molecular weight heparin versus DOACs, mainly because it seems that down to a creatinine clearance of 30, all right, it looks like DOACs and low molecular weight heparins are pretty much the same, all right? And so, and the evidence for creatinine clearance, for low molecular weight heparin or DOACs for patients with a creatinine clearance of less than 30, it's pretty terrible anyways, all right? And so it doesn't really help you to choose one agent versus the other. Now, many of you will know, all right, that we do have regulatory approval for apixaban and rivaroxaban and even edoxaban, all right, for down to a creatinine clearance of 15 to 29. And I have to say, I have not really been using these agents with such a low creatinine clearance, because often these patients have other reasons to bleed as well. And there are no clinical studies to support this. The regulatory approval was really entirely based on PK studies that was extrapolated from clinical trials. So I'm weary of it. And but again, basically creatinine clearance of less than 30, this is really, individualized in your decision, and obviously the patients need to be informed. There has been a post hoc data from Caravaggio that actually showed a much higher risk of clinically relevant non-major bleeding with apixaban than dalteparin in patients who actually have just impaired renal clearance. So there was no difference in major bleeding, but when you looked at clinically clinically relevant non-major bleeding, there seemed to be a signal. So again, it's a post hoc data, but it just we all need to remember these are patients who already have an increased risk of bleeding. And finally, most people would agree you should use low molecular weight heparin if a creatinine clearance is less than 30, or if they're dialysis dependent, and try to use anti-10A monitoring to help you do this. And I've had a couple of patients where I've used full dose tinzaparin for 3 months at full therapeutic dose, with anti-10A monitoring, and they don't bioaccumulate. So, it's an N of 1, N of 2 sort of thing. But I think it does show that with anti-10A monitoring, maybe, we are able to use both low molecular weight heparin and DOACs. Obviously, it depends on whether you have access to DOAC, anti-10A levels and monitoring. New thing for DOACs, obviously, is liver. And when we didn't have DOACs, I never really thought about sort of liver function. But with DOACs, it comes up quite frequently because all of these agents are significantly dependent on hepatic clearance. And clearly, if the patient has, coagulopathy from liver impairment, that's going to increase the risk of bleeding, regardless of what anticoagulant therapy. But because DOACs do depend on the liver, all right, and so these are actually all the oral 10A inhibitors, because the bigotrand is primarily renally cleared. You really just need to sort of think about hepatic dysfunction for the 10A inhibitors. It's also important to remind yourselves, which this is something that, again, I never really paid attention to before, is that, in all of the clinical trials, patients with hepatitis or liver dysfunction, all right, were excluded. Okay, and so in cancer patients, it's not uncommon to see a transaminase over 3 times upper limit of normal, or even a bilirubin of 2 times upper limit of normal. Now, with low molecular weight heparin, I don't worry that much because low molecular weight heparin is not cleared by the liver, all right? But with DOACs, it does make me worry, and I've had a number of patients where I've held their DOACs when they do develop hepatitis or hyperbilirubinemia, because I don't know how they're cleared. And also, if you have liver dysfunction now, it could affect plasma protein binding of other drugs. So whether that's going to now impact drug-drug interactions even more, we don't know. And it is in all the drug monographs, all right, even though these were not explicit contraindications in the clinical trials, that patients with Child-Pugh class B, all right, or C, should not be using DOACs. So for B is rivaroxaban, and C applies to apixaban, rivaroxaban, and edoxaban. And so, C is usually pretty bad. You wouldn't sort of miss these patients because they're usually quite jaundiced, big ascites sort of thing. But B is sometimes borderline, so you kind of have to pay attention to this. And this is a slide actually to show you how common hepatitis and colitis are in patients on immunotherapy. So this is like a large administrative database that basically documents all the AEs that's reported with immunotherapy. So you can see, there's a large number of AEs, but, hepatitis and GI toxicity represent at least about 20%, of all the reported AEs and SAE. So it's quite common. It's unpredictable. It may occur early on in their immunotherapy, could occur later on. So again, it's just something to sort of think about and track with your patients. So all of those things I just talked about had to do with bleeding risk, all right? So the next things really is to sort of look at the type of cancer. And the type of cancer in the algorithm really is talking about GI and GU cancers. So in 2018, the wording was anybody with active GI cancer or urothelial tumor should use low molecular weight heparin. But in 2021, this was sort of narrowed down in that only patients with unresected intraluminal GI or any GU cancers, all right? So the GI was sort of narrowed to just unresected intraluminal, but the urothelial, which really just is bladder, ureters, and renal pelvis, were expanded to include prostate and testicular. And this is largely because of the results in the Caravaggio studies and subsequent studies looking at apixaban that actually sort of gave us this nuance. So this is the HOCUSI study that really showed us the difference between eating in patients with GI cancers versus non-GI cancers. So you can see in GI cancers, huge difference between edoxaban and dalteparin. All right. So with edoxaban, major bleeding, almost 13% of the patients in those who had GI cancer, all right, versus only 4% in dalteparin. And if you didn't have GI cancers, there wasn't really any difference and a much lower risk of bleeding overall. And then Caravaggio came along, and basically they showed that if you have GI cancers, they didn't find any difference in major bleeding between apixaban and dalteparin, but they did find that clinically relevant non-major bleeding, there was a difference with more bleeding with apixaban. All right. But they did say that actually all the major bleeding as well in the GI cancers occurred only in those with unresected luminal cancers. So to suggest that, perhaps in those who have completely resected cancers, there isn't that increased risk of major bleeding. The study also showed, again, patients on antiplatelet therapy had a higher risk of bleeding as well, not surprisingly. And in the Caravaggio study, this is where the genitourinary signal came in. You could see, apixaban 18.2%, all right, major bleeding versus 4.3% in dalteparin. So, the more we sort of more information we have from various studies, the more nuances we're going to be sort of applying to various tumor types. But certainly, I think in clinical practice, we sort of see this pattern anyways. Finally, drug-drug interactions. I don't think there's anything smart for anyone to say here other than that for DOACs, they exist. You need to look for them. And, again, this was this was something in the clinical trials that, again, they restricted patients, all right, who were taking CYP3 or P-glycoprotein inhibitors and inducers. They were excluded from the study. So there's no way we will know, are there potential drug-drug interactions, right? Because yes, this is theoretical, but because they were all excluded in the randomized control trials, we don't really have a lot of data, all right? And so also we have to remember, none of the randomized control trials actually included patients on immunotherapies, because at the time that all of the DOAC studies were running, immunotherapies were not sort of very in common use at all, right? Whereas now we see a lot of them, all right? So again, because not just for drug-drug interactions, but because of the hepatitis and colitis, you kind of have to remember this. So always review your DDIs before you prescribe your DOACs. This is a table from the algorithm that actually lists the clinically significant drug-drug interactions. So all of these drugs have had publications to demonstrate that there is a clinically significant drug-drug interaction. So you definitely should avoid them. So this is not just theoretical basis, but there's a huge list of anti-cancer drugs, and this is not exhaustive here, where there are potential DDIs just because, again, of theoretical and occasional observations, that sort of thing. So again, a bit of a pain in the neck. Try to talk to your pharmacist to see if they can help you. I go through Lexicomp for all my patients to go through these lists, and I have to say it is a pain, but it's something that you need to do to make sure you are safeguarding the patient. So last group of things to think about are these other factors that the group highlighted, and this is sort of expanded so you could see it. The other factors, obviously, to consider, we always do patient preference, risk-benefit discussion, drug cost and coverage. For us in BC, edoxaban really is the big problem among DOACs because it's not covered by pharmacare. Low molecular weight heparin is now sort of first line we don't have to demonstrate warfarin intolerance now in order to actually get pharmacare coverage for low molecular weight heparin. But there are these other sort of more subtle things that I thought I would highlight with you guys in terms of sort of body weight, renal impairment, things like this that's been updated. So in terms of body weight, all of you know extremes of body weight really just have not been adequately studied, and we're seeing more and more patients at the extreme ends. And in 2021, actually, ISTH Subcommittee on Control of Anticoagulation updated. So this is not specific to cancer patients, but they did update their guidelines, and they feel that the use of any DOACs up to a BMI of 40 or a weight of 120 kilos is appropriate. So you don't, they feel you don't have to be anxious anymore about using DOACs up to that weight. And in fact, they said for patients above these thresholds, rivaroxaban and apixaban are among appropriate anticoagulant options, regardless of high BMI and weight. So basically that throws out any sort of limit for weights whatsoever for rivaroxaban and apixaban, and the data are a bit stronger and more robust for rivaroxaban. So so there you have it. And the committee also recommended that, obviously vitamin K antagonists and weight-based slow molecular weight heparin and fondaparinux are also options. It did suggest not using dabigatran, edoxaban, or betrixaban because there's just been weak or no data for these specific DOACs for these sort of high weight patients. And they also actually suggest that not to regularly follow DOAC levels. So they've really kind of just, let go of the, there seems to be no restriction anymore on high body weight anyways. Again, I don't know if I feel entirely comfortable, but thankfully, usually it's a small group of patients at these very extreme body weights above 120 anyways. Now, on the opposite end of the scale, patients who are less than 50 kilos, there's even less data, but the data available suggests that they do have a high risk of bleeding with anticoagulation. And that's possibly because such a low body weight really is another indicator of frailty, it's another indicator of, advanced cancer, or other things, malabsorption, whatever. So these patients are sick for other reasons. Now, the Canadian CAT consensus, recognize these recommendations. But again, this is largely in patients without cancer. And in cancer patients who are more hypercoagulable, it just felt that, well, for patients over 150, use low molecular weight heparin and use the uncapped weight-based dosing as opposed to DOACs. And if you're going to, for patients who are underweight sort of thing, again, use a weight-adjusted dosing, such as edoxaban. So for edoxaban, you can use the 30 milligrams for anybody less than 60 kilos. And of course, you can use weight-adjusted low molecular weight heparin. So there is a little bit of a, not a disconnect, but again, just more subtle sort of focus on that, cancer patients more hypercoagulable. So maybe the data in the general population in terms of the high weight cutoff does not apply. This is looking at incidental versus symptomatic thrombosis. And this is particularly important for cancer patients because cancer patients, have a lot of incidental thrombosis. And depending on the study, more than 50% of now thrombosis in cancer patients are incidental PEs picked up because of staging CT scans. And there's now a publication of a meta-analysis of the 3 randomized control studies, SELECT-D, Hokusai, and Caravaggio, looking at the 3 main DOACs that looked at the incidence of recurrent thrombosis and major bleeding, comparing incidental versus symptomatic. So you can see that it appears that in patients with incidental index thrombosis, their risk of recurrence is statistically significant, like 38% lower than the patients who have symptomatic disease, and that these patients may actually have a higher risk of bleeding, compared to patients who have symptomatic disease. So if you put this all together, it may not be favorable for patients with incidental CAT, all right, to receive very aggressive anticoagulant therapy or to receive a very extended duration. But this is really the only data available. Here I've shown you the data actually from Caravaggio. And again, in Caravaggio, very strongly shows that basically recurrent thrombosis much higher in the symptomatic group, all right, doesn't seem to be much difference in major bleeding, all right, until you get beyond sort of 90 days. So again, you know, in the past, we certainly still treat patients with incidental thrombosis the same because, you know, 5% risk of recurrence is still sufficiently high for us to treat them. But again, you may want to think about, well, do I want to be really aggressive with the anticoagulant therapy if they're having, you know, like perioperative sort of, right, interruptions, that kind of thing. Maybe we don't have to be worried as much as with the symptomatic clots. I threw this in here. It's not in the algorithm, but I thought it was also very interesting because it, again, aligns with, you know, smaller clot burden. Do we have to be sort of as concerned? And I thought this was interesting because this is a very large population database from California that included data from 62,000 patients with cancer-associated thrombosis. And they looked at basically patients with isolated distal DVT and asking, well, basically, is there risk of recurrence, you know, the same? Is the risk of mortality the same as patients with proximal DVT on PE? And this figure nicely shows you that for all the various cancer types, you know, distal, all right, isolated distal DVT in green, all right, it's not that different than proximal, all right, DVT or patients with PE. So it does suggest that, yes, in cancer patients with isolated distal DVT, we still need to treat them, and we still need to treat them as aggressively as we would proximal DVT and PE. So again, not in the algorithm, but this is sort of really recent data that I thought certainly helped me, was new to me. Abnormal uterine bleeding, something that, again, we didn't really talk about or think about with low molecular weight heparin, but now comes up a lot with the direct oral anticoagulants, and it's actually sort of, you know, one of the focuses of the COBRA randomized control study comparing rivaroxaban and apixaban. And I think we all know, you know, we've seen sort of a higher report of you know, abnormal uterine bleeding, you know, heavy menstrual bleeding in women when they're on DOACs compared to when we used to use low molecular weight heparin or warfarin. And if you look at studies, you know, abnormal uterine bleeding is reported in up to 70% of women of reproductive age. I mean, based on my own experience, I would agree with that. And it does seem to vary by DOACs, and this is why right now there is a randomized control trial comparing apixaban with rivaroxaban, all right? And the Canadian CAT Consensus Committee basically added this as something to sort of to be mindful of, and it did say to recommend low molecular weight heparin over DOACs in women with abnormal uterine bleeding while on DOACs, all right? So it's not before you use an anticoagulant, use low molecular weight heparin, but perhaps prefer low molecular weight heparin if they're already bleeding on DOACs, which I thought was okay. Yeah, I mean, that makes sense, right? Like if they're already bleeding on DOACs, it makes sense I might have to switch anticoagulant therapy. But so again, we certainly need more data in this area. And finally, this is something that, again, I never paid attention to in terms of GI absorption. All of you know DOACs are absorbed in the GI tract, but they are absorbed in different parts of the GI tract. So if you look at rivaroxaban, primarily in the stomach, apixaban throughout the GI tract. And so this does have an implication when cancer patients, for example, are undergoing major GI surgery. And so the ISTH 2021 actually recommendation says to not use DOACs for patients who've undergone bariatric surgery. So, this would then perhaps apply in cancer patients who've had a Whipple's procedure, other gastric or duodenal bypasses, if they've had significant small bowel resection, a right hemicolectomy, because more than 50% of apixaban is absorbed in the ascending colon, or even if they have like profuse diarrhea or short transit time, because the DOACs are kind of flying through the gut and perhaps not absorbed adequately. And there's now retrospective studies to, show that dabigatran and rivaroxaban, all right, have significantly reduced levels after bariatric surgery. So again, we wouldn't use dabigatran in patients with CAT anyways, but we do use rivaroxaban. So what I usually do now is, in a patient with, say, gastrectomy, partial or total, I would not use rivaroxaban. And I would consider using apixaban, but I do actually check their 10A levels, just because I'm uncomfortable not knowing how much of the DOAC may or may not be absorbed. So the committee, though, did say that, until further evidence is available, consider using low molecular weight heparin in patients with impaired GI absorption, or at least monitor the DOAC with 10A levels. So this is my second last slide, I think, actually. So having gone through all of that, and if you remember how complicated the algorithm looked, these are the buckets I throw my patients in when I approach them. And this is actually published in a review that Christian Sanfilippo and Marcello Dionisio and a number of others, we wrote together. So we kind of threw patients in the buckets of, is there a high bleeding risk? All right, so we're looking at tumor sites, platelet counts and platelet function, renal and liver function, and a bleeding history. If they don't, then are there drug interactions? So potent modulators of CYP3A4, P-glycoprotein, or if there are multiple interactions. So that means, like, if a patient's on like 3, moderate CYP3A4 inhibitors or, inducers, then we may not know what the final sort of soup comes out to. But if they don't have drug interactions, then ask about drug absorption. Is the GI tract basically intact? Is it able to absorb the DOACs? And if all 3 answers are, no, absolutely, go ahead, use DOACs. But if any of them are yes, maybe to consider use low molecular weight heparin DOAC. So again, this is kind of my version of the algorithm. So all these bits and pieces are in the Canadian CAT algorithm, but I just want to share with you, this is how I kind of think about it, because I don't sort of think of the tumor site, for example, separately, because they really fall under bleeding risk for me. So this is my last slide. Low molecular weight heparin, DOACs, good options for treatment of CAT. Efficacy and safety, I would say roughly balanced in most patients. Bleeding risk, drug-drug interactions, GI tract status are the key factors in selection. Preference and drug accessibility obviously are important, and it's also important to remember the best drug can change over time, because patients have surgery, they have different chemo, they might have metastatic disease, that sort of thing. So always have to reassess, and you may have to change anticoagulants, mix and match them perhaps even sometimes. And it's also important to consider that there are still many subgroups that were excluded from clinical trials and still very poorly studied. The group of high risk of bleeding, this was completely subjective, basically investigator based. So it's hard to know what some of these patients are. Patients with a poor ECOG status, 3 or 4, we see a lot of these patients in clinic, and they were not included. Renal hepatic dysfunction, just something to keep an eye on. Primary metastatic brain lesions, all of the randomized trials except for Hawkeside excluded these patients, but Hawkeside I think only included like 13 patients in this category anyways. And of course, acute leukemia is always excluded. So, we don't, so we only use low molecular weight heparin in these patients, and also largely because they have severe thrombocytopenia for an extended period. And finally, concomitant use of P-glycoprotein and or CYP3A4 inducers inhibitors. this is always going to be a bit of a hit and miss. It's always great when you go through the list and none of the drugs check off, and then you can use DOACs in your patients. But it is important to check. And every day I learn something new about drug-drug interactions. So I am at 5:23, so I did finish on time, but I probably didn't leave enough time for discussion or questions, but the floor is now open. I'm going to stop sharing so I could sort of see everybody maybe. Or because if you have your hands up, I think, oh, I see Taylor.
I had a quick question, Aggie. That was awesome. Thank you so much for going through that. I apologize. This is about the case fatality in cats. So I'm sorry to Lim and Wendy. I had not seen their paper. I was surprised by those numbers just because I know that in non-cancer associated thrombosis, the case fatality for bleeding is, quite significantly higher than the case fatality for recurrent VTE. And so I had been kind of operating under that assumption that it was the same in cancer. And so someone who is, after you've treated them for 3 to 6 months, if they're at high risk of bleeding, I've considered stopping it because of that case fatality. And so is that with that inverse pattern in cancer associated thrombosis, do you then push harder to continue long-term anticoagulation in someone who is going to be at, a very high risk bleed?
Yeah, so great question. I think we were all, certainly a bit surprised about that big difference as well. And Wendy and Lim did a great job. Like, we went through a whole lot of papers. But I think everybody recognizes that, the diagnosis of a fatal PE in a cancer patient is extraordinarily difficult to make. So even though these were, randomized control trials where they did have clear criteria, right? And prospective cohort studies, also clear criteria, it's still very difficult. And then, remember that plot, like the dots were all over the place, right? So there is a lot of uncertainty, I think, with the case fatality for recurrent thrombosis. But we also have to remember, if you look at autopsy studies in the past, 50% of patients with cancer, do have evidence of PE at the time of death. So we may be missing it altogether. Even if you just think about like incidental PE, right? Like a dime a dozen now, kind of, right? And so clearly we're very, very bad at picking up PE, and these patients they have so many reasons to have, shortness of breath, fatigue, that sort of thing as well. So it's hard. But I think based on that, and also I didn't have time, but just showing what's the increased risk of recurrent thrombosis. So basically up to 5 years, the risk of recurrent thrombosis, symptomatic recurrent thrombosis, is still substantial. Actually between 6 months and 12 months. So this is actually Rob Schmidt's data from our own clinic. And I see Rob is here. He was able to show the risk of recurrent thrombosis on anticoagulation. It's actually still 9%, between month 6 and month, like sort of 18, right? So on anticoagulation, it's still 10%. And whereas the risk of major bleeding is about 5%. So I think that balance still favors continuing anticoagulation in these patients beyond the 6 months. Totally for sure, I would say up to a year based on Rob's data. And this is our own sort of data from Vancouver. But perhaps beyond that, you really have to look, because, those patients who are beyond a year, some are cured, some are off chemotherapy, some are on other things. So you just have to constantly relook.
Thank you.
You're welcome. Any other questions? I don't know if I'm seeing everybody, so if I don't call on you, just speak up.
I see some questions in the chat here.
Oh, right,
the
chat. Where's the chat? Okay. So Anna, can you explain why apixaban is better tolerated in patients with liver disease than Riva, even though it's now I did not say apixaban is better tolerated, but I did just say that apixaban is approved down to a the Child-Pugh class, so it's approved in B. but rivaroxaban is not. So this was entirely some sort of a regulatory decision, and perhaps based on what the data the drug company was able to present. In terms of, obviously there's no head-to-head comparison, and I agree with you, it just doesn't make sense at all. This goes along with, it's never made sense why rivaroxaban is once a day when the half-life of rivaroxaban is actually shorter than apixaban as well. So, these things really directly reflected sort of the marketing decisions that the companies made based on their phase 2 data when they sort of developed the trials. And then speaking of drug-drug interactions, Paxlovid interacts with DOAC. Yes, totally does. Pain in the neck. I don't know if any of you have had to order Paxlovid in your patients. So there's a huge algorithm about, what you have to go through. So yes, definitely a pain in the neck. And, if we had edoxaban, we could have used edoxaban, but Pharmacare would not approve it. But it allowed us to use the Vigatran, but nobody would, switch from rivaroxaban to the Vigatran. So I think right now the recommendation was to sort of switch to apixaban 2.5 BID as sort of the more practical option, just to sort of lower the dose of the apixaban, just because the drug-drug interaction with Paxlovid would actually increase the DOACs. Next question, any chance we might get approval for edoxaban? As far as I know, no. I know the company has tried on multiple occasions, and for whatever reason, they continue to be blocked. I have no idea. It's very frustrating. And actually at the last, Pharmacare sort of when they contacted us about low molecular weight heparin, we actually reviewed edoxaban as well. And, and they still didn't. So I don't know. I have no idea why. And then Benjamin, I've gotten special authority for edoxaban by arguing low weight ones and drug interaction ones. Yeah, so you definitely can get edoxaban, but this is on a 1-to-1, and you have to argue. You can't just submit it and have it approved. You have to provide all your reasons and stuff, and it goes back and forth a few times. So yes, sometimes I definitely have done that. And yeah, so Tony agrees, just writing more letters, because none of us have enough time, on enough work on our hands. We have, all the time in the world to click things on Cerner and to write letters and to, do our own transcriptions. But anyway, I digress. Any
quick question, and just wanted to hear what everybody does. I guess what I'm struggling nowadays is I'm starting to collect patients that are kind of in the maintenance phase of cancer treatment, where they're kind of in remission, but getting these weak chemo like TALL, and they're in maintenance with mercaptopurine and methotrexate, which, rheumatology patients get anyway. And just what everybody's doing in terms of anticoagulation, do they stop at that point or just continue on because of a high risk of, recurrence? And same thing with myeloma. Myeloma is considered incurable, and yet we, think that we put patients into remission, but we know they're going to relapse. So what do people do with that on a long-term basis?
Yeah, no, great question, Ben. So, I mean, this is the sort of the growing group of cancer patients, right? Just because, with immunotherapy, everything is sort of changing. I have this one woman with metastatic lung cancer, and she's out like 7 years. I mean, she's been off immunotherapy for 3 years already, and there's nothing. And she's got so many other comorbidities as well. I'm always surprised when she, shows up in person in clinic, because I always keep thinking, oh, she's not going to make it to the next one, but she keeps coming back. But yeah, so there are lots of these patients, and nobody knows what to do, because the ability to collect the data in such a real time sort of, it's just not there, right? Like the California databases actually are already incredibly sort of, advanced, right? And that was like I can't remember, like 2018, right? So that's already 4 years out from, cancer treatment, which is already drastically different, right? Just think about myeloma. So we're always behind. But what I think I'm going to share this screen again, if I may. So I don't know if you guys see this now. So this is Rob's study. So Rob Schmidt looked at the data from our thrombosis clinic and basically took all patients who were still alive at 6 months, and he followed them up to 2 years. So basically he was able to show, all right, that the risk of recurrent thrombosis is 8.2% overall, all right, over up to 2 years. So you could see, like, the curve is still going up. Like, it's not really maybe plateauing, I don't know, but it's certainly, up to 2 years after their index clot. And if you look at bleeding, also the same, all right, and that's not surprising. And this is clinically relevant bleeding. What surprised us a lot more, though, is when we actually looked at, maybe this is, I don't know if this will work. Oh, so we looked at then the patients who actually continued on anticoagulation. So you could see the people who continued anticoagulation, risk of recurrence was almost 10%. So clearly, those of us who were treating these people at 6 months looked at them and said, my gosh, you're going to recur. I'm going to keep you on anticoagulant therapy. And then they also looked at patients and say, you know what, you're probably okay to stop. The people who stopped, their risk of recurrence over the next basically, 18 months there, 4.4%. All right. So not terribly high, but also not terribly low, right? And so, how good are we able to put patients in these two buckets? I don't know. I mean, this in some ways makes me proud that we actually do a decent job, because clearly these were going to be, if they were off anticoagulant therapy, they would have recurred at a much higher rate. And then when you look at bleeding, all right, not so bad. And if you come off anticoagulant therapy, the risk of bleeding is still about 2%. All right. If you stayed on anticoagulant therapy, it's about 5%. So even within the group that stayed on anticoagulant therapy, the risk of recurrence is still twice as high as the patients who came off anticoagulant therapy. So if you just go on that alone, and if you look at case fatality, it still kind of argues we should keep these patients on anticoagulants, right? Again, but remember, these are all comers, right? So you have one patient in front of you, all you can do is do your best. And right now, we don't have good risk scores for bleeding at all in this group. And in fact, there's been a number of studies published in the last year formally looking at various bleeding risk scores and apply them to cancer patients to see whether they were predictive, and they were disasters. Basically, 0.5 was like, it's like you flip a coin, totally unusable, right? So, atria, hemorrhages, and even stuff that were developed specifically for cancer patients. So we're very, very bad at predicting bleeding. And that's about it. And here's another prospective cohort study that looked at also showed us what's the risk of bleeding and recurrence. So this is a prospective cohort study, Cleveland Clinic, 284 patients, all right, followed between 2014 and 2018. And basically they said, after 6 months, a third of them did not continue anticoagulant therapy. And why? Well, 46% of them discontinued for various reasons, including financially. 36 stopped because they were deemed at low risk of recurrence, and 13% stopped because they thought the risk of bleeding was too high. All right. So they followed these 284 patients, with a third of them stopping anticoagulants. The risk of recurrent thrombosis in this group was 12%. Risk of major bleeding was 2%, right? So again, based on our gestalt trying to sort out the people who weren't going to develop recurrence or who weren't going to bleed, we just do a bad job, right? Especially it looks like recurrence, right? So, and if you look at, the people who continue, the risk of recurrence, all right, and continue anticoagulants, risk of recurrence is 12%. People who stopped, 12%. So again, these patients would have recurred at an even higher rate if they had stopped, right? And clearly not very good at selecting the people who could stop, right? Because 12% of them developed recurrence. And whereas bleeding, there also didn't seem to be a very high risk of bleeding, but overall the bleeding was kind of surprisingly low. Once they, 13% of them did stop for bleeding. So I guess maybe the approach may be that, if there's a risk for bleeding, then stop, right? But otherwise you would continue. Also in this study, they showed recurrent thrombosis associated with worse survival, almost twofold higher, statistically significantly different. So I think all the data, maybe it's a publication bias, I don't know, but really do push us that we need to continue anticoagulant therapy unless there is a reason to stop because of bleeding. But maybe my personal bias, that's how I'm sort of looking at the data. Okay, it's 5:38. I actually need to be at the school for 6 o'clock. So I'm going to be a little bit late, but thank you, you guys. That was great, and happy to revisit this again later.